Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a white, mature, non-intermittent cataract. Nuclear sclerosis is about grade 3. The nucleus is not very hard. I have taken up this case for surgery. This is a totally unedited recording. Let us observe the surgical steps. This is the main incision with a 2.8 mm keratom on the posterior aspect of the limbus, and now this is a paracentesis on the left side of the main incision about 2.5 clock hours away. Now this is an air bubble that fills off the anterior chamber. Beneath this air bubble I am going to inject trypan blue 0.06% dye to stain the anterior capsule of this white cataract. If you stain the anterior capsule underneath an air bubble, staining is immediate and it is very good and takes very short time. The dye is washed out, and now 2% hydroxypropyl methyl cellulose is injected into the anterior chamber. Here it goes. This is 2% methyl cellulose. It has filled off the anterior chamber. It is sprayed over the corneal epithelium for better visibility, and it protects the corneal epithelium very well. Now this is another side port on the right side of the main incision. In this case I have planned to use bimanual irrigation aspiration, and that's why this is another side port. And now the anticapsule is incised to the 26 gauge bend needle. Now I use a Utrata forceps. Always lift off the anterior lip of the main incision, keep it lifted off and move all around. Viscoelastic substance will leak minimally if you keep the anterior lip of the main wound lifted off by the Utrata forceps. Rhexis is complete. Now hydrodissection is not actually required in such cases, but very minimal hydrodissection can be done. It is dangerous sometimes because if it is a posterior polar cataract, precedent can occur during this step itself. And now nucleus management. The tip of the phaco handpiece is introduced with its bevel down. Some superficial cortical lens matter is removed. Now the handpiece is turned and the bevel is up towards the cornea. And now the tip is buried into the substance of the nucleus, and here it is. You just chop the nucleus. How far will you go depends on the hardness of the nucleus. In this case I am not going beyond the middle part of the nucleus. If it is a very hard cataract, I can cross the middle part, go near the opposite equator and then chop it. Nucleus management is complete. In this case phaco power was 55%, flow rate was 40 ml per minute, and vacuum 400 mm of mercury. And now I am going to use bimanual irrigation aspiration. It looks elegant if you use bimanual irrigation aspiration or coaxial irrigation aspiration. First I am hydrating little bit. Now irrigation is from the right side port and aspiration from the left, and now the cortex is removed. It is effortless. It comes very easily. Only the soft side port cortex you have to change hands and go from the other side to remove that. Sometimes you can manage from without changing hands also. And now this is hydro polish. The posterior capsule is being polished by hydration. And now here some more fibers are there. They are removed in IA2 mode. In this case the flow rate was 20 and vacuum was 30 millimeter of mercury in IA2 mode. And now hydro implantation. Antechamber is kept formed by irrigation. Here it is. Antechamber is kept formed and the IOL is injected into the anterior chamber. This is a hydrophilic acrylic intraocular lens. Very good lens. Yes, PCO can occur, but you can use your ear glazer to make a posterior capsulotomy if it occurs. Otherwise this lens is very good. And now the side ports are closed by corneal stromal hydration. BSS is injected into the corneal stroma. At this time inject towards the sclera. Keep the direction towards the sclera, not towards the cornea, not towards the center of the cornea. And now see the final lavage of the anterior chamber. A gentle stream of BSS will be directed towards the corneal endothelium, and you will see how much visco sticks to the corneal endothelium. Here it is. You can see a layer of visco is getting displaced. Yes, if you direct a gentle stream towards the corneal endothelium, this visco also comes out and it doesn't cause any harm to the corneal endothelium. Antechamber is formed very nicely. Now the integrity of the wounds are to be checked. Take a cotton tipped Johnson bud, check the wounds. The assistant puts some few drops of moxifloxacin and then you conclude the case. This is a totally unedited recording. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, compassion and great surgical competence.